Hello, my name is Jay Huang. I'm a general pathologist and a junior attending, and I go over cases almost on the daily from head to toe. Today we're going to do something different. This is the ASDP that came out today, the interactive case study, July 2025. I thought this was a great case study to learn about the spindled lesions of the skin, as well as the difference between atypical fibroxanthoma and pleomorphic dermal sarcoma. So thank you to Dr. Archibald, Iwamoto, and Nabel for this interactive and educational case. So this is an 86-year-old male with a painful growing plaque on the scalp. It has been present for about 6 months. So we can see here with some crusting and ulceration, and they did a deep biopsy. As we can see here, we can see a very cellular lesion that goes into the dermis and into the subcutis. Here we see more of the superficial reticular dermis. We see a very atrophic skin, which coincides with this gentleman being a little bit older. And from this power, what appears to be a very cellular infiltrate with maybe giant cells. Closer up, these giant cells, supposed giant cells, are actually very pleomorphic cells. Look how hyperchromatic, enlarged, irregular the nuclei is. And some of these cells have a rhabdoid appearance as well, / signet ring. And it's very pleomorphic. You have some cells that are hyperchromatic but small, but then other cells that are hyperchromatic and large. What we don't see is some pagetoid spread, lentiginous growth, consumption of the epidermis, and pigment. So less likely melanoma, but melanoma is the mimicker of all things. Here we see this the deeper portion of this tumor that has infiltrated the subcutis and kind of reminiscent of the honeycombing that we would see in a DFSP. This doesn't have the storiform architecture, and the cells are very pleomorphic. Here we have some beginnings or in process of perineural invasion, and must have been painful for this patient. Surrounded by some of those pleomorphic cells that we saw in the prior photos in the superficial reticular dermis. Okay, so knowing that the S100, pancytokeratin, CD34, and desmin stains are negative, what is the best diagnosis? So what they're getting at is the SLAM differential for spindled cell lesions in the skin. So SLAM, S for spindled squamous cell carcinoma, and you can identify that with pancytokeratin, and that was negative. L for leiomyosarcoma, and you can identify that with desmin, and that's negative. A, like SLAM with 2 A's. One is for atypical fibroxanthoma, and another is for angiosarcoma. And we'll get to that in a second. M is for melanoma, and so S100 is negative. CD34 could also help identify kind of a DFSP, and that was negative. And then the diagnosis of exclusion is atypical fibroxanthoma. However, a related entity is pleomorphic dermal sarcoma, and the difference is pleomorphic dermal sarcoma will invade the subcutis. So pleomorphic dermal sarcoma is a spindle cell neoplasm thought to exist on a spectrum with atypical fibroxanthoma. Histologically, both pleomorphic dermal sarcoma and atypical fibroxanthoma consist of a dermally based proliferation of pleomorphic spindled and/or epithelioid appearing cells arranged in sheets and fascicles. Mitotic figures are often abundant in both of these entities. Pleomorphic dermal sarcoma is differentiated from atypical fibroxanthoma by demonstrating one or more of the following high-risk features: deep invasion of subcutis, areas of tumor necrosis, and lymphovascular or perineural involvement, which we had seen here. The histopathologic photographs in this case show a pleomorphic spindle cell neoplasm with deep invasion of the subcutis and perineural invasion, making pleomorphic dermal sarcoma the best diagnosis. So UPS, this is not correct. This represents a diverse group of tumors that arise in deep soft tissues and includes tumors that arise in the retroperitoneum, internal organs, and bone. Some argue that the term UPS should not be used to characterize cutaneous neoplasms. Others say that PDS is the term used to describe the cutaneous variant of UPS. In general, UPS tends to arise in the deep soft tissues and has an even more aggressive clinical course compared to pleomorphic dermal sarcoma. Although cutaneous involvement of UPS cannot be entirely excluded in this case, pleomorphic dermal sarcoma is the better diagnosis given that this tumor is arising on chronically sun-damaged skin and appears to be predominantly a dermal tumor with infiltration into the subcutis. A was also pretty common, so atypical fibroxanthoma, we talked about the differences. DFSP, the tumor in this case lacks the classic storiform or cartwheel pattern of DFSP. The cytology in this case is markedly atypical, whereas the tumor cells in DFSP usually have minimal cytologic atypia. Pleomorphic fibroma. Pleomorphic fibromas clinically can resemble acrocordons or skin tags, neurofibromas, or intradermal melanocytic nevi. Histopathologically, they have low cellularity with thick collagen bundles and scattered cells with hyperchromatic and pleomorphic nuclei. The clinical appearance of the tumor in this case, as well as the features of hypercellularity, deep invasion, and perineural invasion, are not consistent with a pleomorphic fibroma. All right. So which of the following is currently considered to be the gold standard treatment for pleomorphic dermal sarcoma? So a surgical removal of the tumor is currently the gold standard. There is some data that shows lower recurrence rate with the use of Mohs compared to excision. However, the sample size in the study was small. Okay, how do the estimated rates of local recurrence and metastasis compare between pleomorphic dermal sarcoma and atypical fibroxanthoma? So pleomorphic dermal sarcoma has higher rates of local recurrence and metastasis compared to AFX. The estimated rate of local recurrence for pleomorphic dermal sarcoma is around 30%, and the estimated rate of metastasis is 10%. In contrast, atypical fibroxanthoma has an estimated rate of local recurrence of 5%, and metastasis is very rare. Unfortunately, the patient in this case had PDS, or pleomorphic dermal sarcoma metastasis to a cervical lymph node. All right, well, that was a great case. Thank you to Dr. Archibald et al. For this case. Thank you for ASDP. I will see y'all next time. Bye.